over to Commissioner Turner to say a few words. Commissioner, I believe you are muted. So if you are talking, we are not hearing you.
Hey, Kara, I'm sorry. My phone got disconnected. I apologize. Sorry about that. Can you hear me now okay?
Yes, we're good. So
okay, perfect. Excellent. Thank you. Good morning, everyone. Certainly appreciate you guys joining us this morning and looking forward to a robust discussion. As Kara alluded to, I'm sure if you've had chances to send some questions through the inbox, please continue to do that because we certainly appreciate the feedback and being able to try to answer those questions. And if we don't have an answer for you, we certainly want to make sure that we get you one. So I know there's been some questions that have been submitted this morning. I think this continues to be a very valuable way for us to stay connected, not just through the pandemic, but holistically as we work together to try and provide the right level of support for individuals that we all care about. So I appreciate, again, what you're doing and certainly looking forward to the discussion this morning. With that, I'll turn it back over to Kara and let us get started. Thanks, Kara.
Okay, just a few things before I turn it over to Dr. Davis to talk about testing and give an update there really quickly. First of all, in case you have not seen, we have done two things. One, we have scheduled a family-focused presentation for IDD integration for next Thursday. I believe that date is the 20th from 3 to 4 p.m. Central. In the initial feedback we received through our stakeholder feedback, we found that families were not able to really ask the questions they wanted, nor were they, because a lot of providers obviously asked questions. A lot of the information was very provider focused when we came to answering some of those questions, which of course we were here for everyone. But one of the things we thought we would want to do is focus it more on the services that people are receiving, how these changes could benefit people, and really give families an opportunity to ask the questions in an environment where they can hear from other families as well. So we're looking forward to giving that. And because we want to make sure that we allow plenty of time for feedback after that, we are extending the stakeholder feedback in input until the 28th of August. Originally, that was set to expire yesterday, but since we could not schedule this family-focused meeting and that initial feedback really indicated that we needed to do that from some of the first families we heard from, we wanted to make sure that we gave ample time for comments. And I would say this is where stakeholder input is important. We would not have known that families felt confused and overwhelmed in some of those initial WebEx meetings if they had not weighed in. And so we're very grateful that they did. And because of the feedback we've received, we're trying to make sure that we can do something that really benefits them and the people that we support. So that's my spiel on that. Obviously, the comment box is open, and I'm going to now turn it over to Dr. Davis to give us an update on testing.
Yes, I think many agencies have begun to arrange for their testing supplies through the Department of Health, and that's a very good thing. The testing supplies are for our waiver agencies are for monthly testing for our ICF settings. So if you're providing services in an ICF setting, then the Department of Health is recommending weekly testing, and so you can order supplies in accord with that. A couple of things that I've found in these orders that have been made for tests are, first of all, that some agencies are trying to get too many tests. You should only order at most for the week upcoming, or you could order, if you're ordering on a monthly basis, then you could order a few extras, maybe at 10%. But if you have an overage, you're to deduct that from your order for the next month. And so they are sending all of the requests over to the department, to our department, to review, to make sure that it's in line with the number of people that you serve and the number of staff that you likely have. We'll often be reaching out to you if the order seems like it's a little bit out of whack with what we think it should be. And so please make sure that you make those orders appropriately. Also, I want to remind people that the email address for questions about the testing itself, maybe to send in your memorandum of understanding to the Department of Health, is covid19.testing@tn.gov. And the reason I mention that is that we received one request, one memorandum of understanding through our COVID-19 email address here at DIDD. So we want to just make sure that people are aware of that. So thank you. Kara?
Okay, and we'll get to the questions that I see in the chat box after we get to the questions and we finish with the questions that we've received that were pre-submitted. So I do see that we have some questions, and we'll definitely come back to Dr. Davis to answer some of those. So the first question we got into the COVID inbox was, can you tell me if DIDD is entering the billing for the COVID-19 rates for the companies, or is this something that's to be entered by the companies themselves? Deputy Commissioner Andy Kidd is on the phone, and so he will join us and answer that question.
Thanks, Kara, and good morning, everybody. The providers will be entering their own billing for those. We are currently working on getting those rates, the actual service codes in the system, and once that's complete, the regions will be reaching out to each of the providers specifically once that request has been approved, and then you're going to be entering that billing in yourself, and we'll provide instructions that go along with that, with specifically what codes you need to enter. Thank you.
Thanks, Andy, for that. So the next question we have is one, I'll read it out loud. We have been told that some agencies in the Nashville area are allowing COVID-positive staff to keep working as long as they wear a mask. Our agency policy is that if they have been exposed, even if they test negative, and certainly if they test positive, they have to come off the schedule and be quarantined for 14 days before returning to work. If every provider is not following the same measures, how are we ever going to stop the cross-contamination that is going on between agencies? Is the department able to do something to try to mitigate these issues? Dr. Davis, I know you wanted to address this.
Yeah, so the first thing I want to say about this is, at this juncture, we consider it unacceptable for a positive staff member to work until they have cleared and been cleared to come back to work according to criteria that the CDC has established. Now, if your agency finds itself in a position where you think you have to go to this level to staff, then we need to know about that, and we need to consult with you on alternatives to that. I just do not think we're at a juncture yet where we would consider doing that. And so if that is your approach to this at this point, we need to hear from you. We also need to hear from others if they're aware of agencies that are doing this, so we can reach out to them. I don't want to reach out in a punitive way here, but I do want to make sure that we're all of one accord in how we should be approaching this type of situation, Kara.
All right, thank you very much, Dr. Davis, for weighing in on that. The next question we have is in regards to IDD program integration, and it's must providers try to get contracted with ECF choices along with the MCOs prior to July 2021. Jordan is on the phone, and I believe he can answer that question.
Sure. Thank you. Good morning, everybody. And it's a good question. We addressed a little bit of this last week, and we'll continue each week to make clear two things. First and foremost, on the 1st of July, 2021, DIDD will formally take over the credentialing component for agencies wishing to provide supports in both the 1915C and the Employment and Community First Choices, the ECF program. Between now and then, agencies, I guess I'll lay it out in three different stages. If you're currently a provider agency who is authorized to provide services in both the ECF and the 1915C waiver program, and you have contracts with each of the three managed care organizations for the ECF programming, then you won't need to do a thing between now and the 1st of July next year, or after the 1st of July for a period of at least 6 months and maybe up to a year while we finalize the credentialing requirements that eventually will take hold within the network. If you're an agency right now who is contracted to provide services in the 1915C program, but not in the ECF program, then two things will happen. On the 1st of July 2021, you will be effectively credentialed to be able to provide services within the ECF network. You will still need to develop a contract with each of the MCO agencies or organizations in order to be able to provide those ECF services, but you will not be required to go through an additional credentialing process. So if you wanted to start seeking ECF contracts with each of the managed care organizations between now and then certainly you're welcome to do so. On the 1st of July 2021, you will be effectively credentialed to be able to do so, but will still need to get a contract with each of the MCOs. If you are currently an ECF provider, but not contracted with the department to provide services within the 1915C waiver, then between now and then you have two choices. Between now and the 1st of July, you can either apply and go through the credentialing process with DIDD to become a 1915C provider, or on the 1st of July 2021, you will effectively be credentialed and you will need to get a contract with the managed care organizations in order to be able to provide 1915C services. So the predominant point with the process that we're engaging is to provide continuity of service for people receiving support. And we don't want to interrupt the provider's ability to continue to provide those supports, while we also work fairly aggressively to streamline the credentialing process. So provider agencies on the 1st of July 2021 need only to be credentialed through DIDD to be eligible to provide services in all HCBS programming.
Thank you so much, Jordan. Appreciate that. So the next question we have in, it's kind of a multi-part question, so I'm going to consolidate a couple of those parts. This person has a son in HCBS who currently has Medicare and Medicaid and Blue Cross. Will he and the others be on Medicare and Medicaid? And who will hire or fire direct care providers in the new system? Will there be an income increase for direct care providers to recruit staff who are better educated and receive adequate wages? And who will direct care providers report to? So Jordan, you want to kind of talk a little bit about that?
Yeah, I'm going to try to keep all those straight. If I miss any, Kara, keep me honest. So as it pertains directly to your managed care organization, nothing will change. So the current managed care organization providing support, and everybody within the waiver system right now has a managed care organization, that will remain the same. So eligibility for Medicaid, Medicare will not change, nor will your managed care organization. As it pertains to network management, as I was describing a little bit previously, the department will take over the lead role in credentialing. So all agencies providing service within the DIDD 1915C program and the ECF program will be credentialed or approved through the department. So we will, if you're a new provider, for instance, the department would take on the responsibility of reviewing requirements, rendering official disposition as to credentialed status, and then at the point at which that agency achieved that credentialed status, eligibility to provide services for the managed care organizations would be established, and again, then individual contracts need to be developed with the managed care organizations in order for the provision of service. So in short, it will be direct network management will be maintained from a responsibility standpoint by each managed care organization, with the department ultimately being the credentialing agent that makes eligible agencies to participate in HCBS waiver programming for our population. There are a couple additional layers to that, and I don't want to pull us too far down into the weeds, but we will have a preferred status category, and then the department will maintain the authority to have a super preferred category where if we need an agency to fill gaps, for instance, and that can be geographical or service gaps, then the department will have the authority to mandate contract status with the managed care organizations for agencies that come through our credentialing process. But in short, each managed care organization will have a pool to pick from. Those will be the providers credentialed by the department. They will develop contracts with these individual providers unless the department needs to take a more affirmative stance based on geography or service needs. As it pertains to the pay question, can you restate that one, Kara? Because we may need Deputy Commissioner Kidd to weigh in on that one.
There was one about will there be an income increase for folks to recruit staff who are better educated and receive adequate wages they can live on. So I believe, will there be thought to the rate methodology as far as direct support provider pay?
Sure. So that, you know, the rate methodologies right now for the 1915C program and the ECF program will not be changing. We are certainly looking toward that single system design and development process, and it may well be that methodology changes at the point at which we develop and implement that programming, but as we've said for a little while now, we are only in the beginning stages of even framing out concepts as it relates to that kind of thing, and it would be after significant development, discussion, collection of stakeholder feedback, ultimately submission and approval to CMS before anything from a methodology standpoint would change. At this point, we certainly have not contemplated or considered additional staff hiring bonuses or anything like that. Andy, I don't know if you have anything additional you want to add, but feel free.
No, I think you got it, Jordan. Thank you.
And then there was a question about the $34 million that this will generate and concern about losing services. And Andy may want to weigh in on this more, but that $34 million in revenue will not come from cutting services to anyone. It will be triggered by an assessment that the MCOs pay for persons in their services. And Andy, you might be able to explain that a little bit better.
No, Kara, I think you nailed it. I think the focus is obviously on the services provided. That's our 100% our goal is to making sure that no services are lost during this transition. The additional $34 million in revenue, as you mentioned, are paid by the MCOs through an assessment that they pay. So it's additional revenue that we'll actually be able to use those dollars to help provide more services in the future. That's one of the flexibilities that we get with the integration that we're going through. So excited about it, but definitely focus is definitely on the services, and it's not a dollar decision. It's definitely a services decision.
Great, thank you for that extra commentary. I think that was important. And then finally, this person's son was selected for the Enabling Technology grant. A budget was prepared and stopped, and they were unsure why. I think Harold Slobes is actually on here to discuss that. Harold?
I'm sorry. I was multitasking and distracted. What is the question, please?
It was about the son, the selected for the grant for Enabling Technology that they met, decided where to start and prepared a budget, but then it stopped and they were unsure why. Harold and Harold, I just wondered if you wanted to weigh in.
Absolutely. Do we know which waiver this person is enrolled? Is it the SD waiver?
I'm sorry, Harold, I don't have that information.
Okay, so let me answer a couple of ways. If it is the SD waiver, then it's probably likely because we had some uncertainty with respect to our state funding to pay for the necessary technology and monthly charges. Universally, people who have been working with our Enabling Technology team who are in the SD waiver have been at their cap. So there was no additional waiver funding to allow them to access the technologies and the monthly support charges through the waiver. So we have been using state funding. It was last week that we got the green light to use state funding for people in the SD waiver, many of whom were at risk of displacement, not all, but many. So whomever this is, if they are in the SD waiver, I gave the green light, as a matter of fact, earlier this morning to please proceed and make that funding available to people. If it's someone in the 1915C waiver, I'm not aware of any reason that process would be suspended, because that is entirely through our Appendix K language and allowances for that to proceed with great flexibility. So waiver funding in 1915C is a non-issue. That should not be a barrier. If there are other barriers as far as the circle, that's a different issue, but there are no funding barriers in 1915C. The only other scenario that I can possibly address is if it's someone who's in the ECF program and living with a couple of other people who are in 1915C. The ECF process for accessing technology is different than ours. But we have made it known that we're available to facilitate that process. So, you know, in summary, it just depends on which waiver the person is enrolled. My hunch is that it's SD waiver, and again, there's no barriers as of today.
All right, thank you very much. We have some questions in the chat box that we will try to get to all of them, as many as we can in the next 8 minutes. Okay, first is if a home has COVID positive cases, is there a different rate structure or billing code to be able to pay staff additional dollars for working with positive people? Deputy Commissioner Kidd.
Yeah, thanks, and great question. So there are two different rates that we are working on getting put in the system. I say two, but there's a variety of rates in there, but two overarching. One is the special needs adjustment rate, and then the personal care rate differential, and that's for positive cases. And so the process for that is you request it with documentation of a positive case to your regional office. And then once we approve that request, we'll reach back out within the next week or two to let the providers put that in the billing system using the specific rates that we provide. I'm actually going to put in the chat box a link to the COVID-19 website with the Appendix K WebEx PowerPoint so that they can look at the specifics on that.
Okay, next question is about how about a staff who tested positive with no or mild symptoms working in a home where all individuals are positive? Dr. Davis.
So in a circumstance, what you're defining there is a quarantine. And under that circumstance, a staff member who has tested positive and is working with no one else except other positive person supported is would be able to work as long as they are asymptomatic. I am going to not accept the mild symptoms aspect of that question and say that if they are completely asymptomatic under a quarantine scenario, they could do that. I differentiate between the term quarantine and self-isolation or in-home isolation, which is where there is a mix of people who are positive and who are negative. And so there should not be a positive staff member working in that setting, even if they're only working with the person who's positive, because there's a great potential for spread within the home. So that I think defines our posture as it relates to that question, Kara.
Next question. Everly Well says each test needed a unique email. How can that be handled if we test monthly? And are there any HIPAA concerns or violations if we are documenting staff temperatures at shift change? Dr. Davis, and then Teresa, our general counsel, might want to weigh in on the HIPAA.
Yeah, I'll leave the second question to Teresa. The first question is related to the establishment of an account. I'm going to check further into this, but I believe what will happen is that the staff member will establish an account, and that same email address will be used each time that they check their results. Once they set that up initially, they will be able to continue to check via that email address that they entered on that first occasion. So that is how I think that works. I'm going to investigate a little bit further, and if I find out different, we'll put out information to that effect. Kara, or actually Teresa.
Teresa?
Kara, could you repeat the second part of that question?
Sure thing. It is, are there any HIPAA concerns or violations if we are documenting staff temperatures at shift change?
Kara, is that question in the chat box? I want to be really careful answering that question for providers because I'm not their legal counsel. I don't want to give legal advice, but there should not be HIPAA concerns. We don't need to give out privacy rights. I don't know the procedures of the provider agency, so I don't want to speak in too much detail on this. I would say that the sheets that are, if they write down the temperature checks, those should be kept in a secured location where other folks cannot access that information. So that's pretty much it. You don't need to hand out the HIPAA privacy rights. Keep that information secured where other folks can't access it, and you should be okay. But I have to stress it, if you're not a DIDD employee, you really do need to ask your own legal counsel. And where that information is secured, make sure that you're following minimum necessary, and only folks who need to have access to that secured location have that access, whether it's a physical or electronic space that that information is stored.
Okay, thank you very much, Teresa. Okay, we have one more question in here, and we have 2 minutes. I'm going to try to get through this answer. It is the experience of this provider that people who have tested positive continue to test positive for weeks and months after they have recovered from COVID. And yes, I think we've all heard of those situations. For clarification purposes, as long as staff who previously tested positive have met the criteria for returning to work as expected by the CDC, a continued positive test result would not prohibit the staff from working, correct? Dr. Davis?
Yeah, that is correct. And so the guidance from the Tennessee Department of Health is that anybody who is tested positive need not be tested again for 90 days after that. And so because it is assumed that they may continue to test positive. The way to clear a person with a positive test is that they have it has been 10 days since the positive test, and that the last 24 hours of that 10 days, the person did not experience any significant symptoms and has a temperature below 100. So, and has had that for 24 hours without the aid of fever reducing medication. So that is the criterion that people should be using to return to work after a positive COVID test.
All right, thank you very much, Dr. Davis. We're out of time, so I'm going to turn it over to Commissioner Turner to see us on out.
Thanks, Karen. Again, great questions today. Certainly appreciate your engagement from the provider network, and just grateful that we're able to try to provide some of those answers on a Wednesday morning. Again, please continue to submit those questions. We certainly want to make sure that that we're able to answer those. We take them very serious, and I hope you can tell that we're committed to continuing this type of dialogue to be able to share information with each other as this thing continues to steam forward. As a pandemic, we want to make sure that we're partnering in the most effective way, and I think communication is key in all of that. So great question today. Thank you for your engagement. And with that, Carol, I'll turn it back to you.
All right, and then just a reminder, we'll be here next Wednesday. We will always take questions that are submitted prior first before we get to those in the chat box. So if you have something you really want us to talk about, please email it ahead of time. And we look forward to seeing you all next week. Thanks all for another great office hours. Bye.